A very good afternoon to all of you from AIG Hospitals. I am Dr. Rajiv Menon, Consultant Cardiology in AIG Hospitals, and with me to co-chair the session is Dr. Swaroop, who is our colleague cardiologist. Today we'll stenting and revascularization strategies, which we started in our previous session. I am sure all of you might have enjoyed the previous session where there was a debate between whether surgery is better or angioplasty is better for left main, and both the speakers gave their point of view, and we got a lot of inputs actually even after the session. This series of webinars which we've been conducting from April, this is the 8th in the series, and we have got excellent response till now with more than 1,500 people trying to attend the session or listening to the sessions over a period of time. As always, we have a faculty with us. Indeed, it is a privilege and it is our good fortune that we have one of the most senior interventional cardiologists in this country, Dr. Shahid Merchant, with us to share his vast experience. I am sure many of those listening to this webinar don't require introduction of Dr. Shahid Merchant. He is one of the pioneers of interventional cardiology. He's got trained in different aspects of interventional cardiology in US as well as in Italy. He is well versed with almost all modalities of intervention, including TAVR, rotablation, renal denervation, and there's practically nothing which he can't do as far as interventional cardiology is concerned. He's been kind enough actually to share his experience. We requested him to share his experience about bifurcation, using a two-stent approach for bifurcation, and luckily he agreed to share that experience. I'm not sure if he has already joined on Zoom. Welcome, Dr. Shahid Merchant. Okay, I think he's joined, but his audio and video is off. So as and when he comes in, I think we'll take comments from him. So without wasting more time, I think we'll go on to the sessions proper. Again, it's going to be an exciting time today because we'll be discussing provisional as well as two-stent strategy and looking at how actually we can take help of imaging optimize our left main results. So we'll start off with Dr. Neelkant, who is again a senior interventional cardiologist with us. And I think you already heard him speak multiple times before. So we'll hand over to him and let us see what he has to tell us about how we can use imaging in optimizing the left main results. Neel, over to you.
Thank you, sir. Good afternoon. I'm Dr. Patil. Today we'll be discussing role of imaging and functional assessment in left main PCI. We'll discuss it over three parts. First, the role of imaging and FFR in intermediate LM lesions, then pre-PCI imaging and post-PCI imaging. Now, significant LM stenosis is defined as diameter stenosis of more than 50%, which correspond to an area stenosis of 75%. And both ACC and ESG guidelines recommend revascularization of all the patients with significant left main lesion, regardless of symptomatic status or associated ischemic burden. This is because of the associated very high mortality and morbidity with the left main lesion. Now let us see where is the plaque located in the left main. In 80% of cases, LMCA disease is associated with atherosclerosis in the other vessels, and isolated LMCA is quite rare, like 15 to 20%. And whenever there is the involvement of left main bifurcation, this carina is usually spared most of the times. And whenever there is a distal left main involvement, a plaque will extend into LAD in almost more than 90% of cases and into L6 in 2/3 of the cases. Hence, isolated LAD ostium or LAD circumflex is almost very rare, say 10% or 15%. Now, before we go to the functional classification, we should all know this law. This was a generalized Murray's law, which states that the volume of the main vessel has to get divided into two daughter vessels, and hence the volume remains a constant, and the cube of radius of the parent vessel is equal to summation of the cubes of parent vessel, daughter vessels. And we have this Finet's law is a simplified derived law from there. which states that the diameter of the main vessel, here left main in our case, would be equal to roughly 0.7 into summation of the diameter of daughter vessels. So say if LAD and L6 are around 3.5 millimeter, then we get 3.5 plus 3.57 into 0.7, 4.9. So diameter would be, LM diameter roughly should be around 5 millimeters. And however, this law actually underestimates the diameter. So it will be 4.9 or slightly higher only. And if it's 3 plus 3, we get 4.2. Now let us see the role of imaging and FFR in the intermediate lesion. Now is angiography enough? We all know the answer to the question. It's not. But first time it was shown systematically by this group Helios et al. In Circulation, where they studied 200 patients with intermediate LMCS stenosis. All patients underwent FFR and QCI analysis. Those with FFR of more than 0.8 were managed medically and less than 0.8 were revascularized by surgery. And 5-year survival rates were equal in both the groups. So this the conclusion was it is safe to defer the patients with left main lesion if the FFR is more than 0.8. In this study, they objectively try to see how the visual assessment fares against FFR. You can see this is the reviewer A and reviewer B. There are two people who assess the lesions independently, and when a reviewer A thought it's significant, you can see that the chances of him being right were almost 50%, and same when he thought it's non-significant. Same was true about the second reviewer, and I don't think it will be any different for all of us also, and we might have this discussion in our own labs. I feel it's significant, you feel it's not significant, and our chance of being right are 50%. That is because there are only two possibilities, and hence this intermediate LM lesion should have some form of advanced assessment and not just a subject to angiographic evaluation. So the conclusion was angiography alone is not enough. And then we all know that FFR is the only index which is matched to objective ischemia. It takes into consideration everything. Left dominant, right dominant, viable, non-viable myocardium, all taken into consideration. FFR would give an idea about whether the lesion is important or not. Now let us see how to do FFR in a left main. In an isolated left main lesion, it's quite simple. We just pass a wire across left main, measure the FFR, less than 0.8, we revascularize. Now current guidelines say more than 0.85, we defer. In between, we should have some additional imaging. This will come to it by this number. If the lesion is involving the left main distal bifurcation, then ideally we should pass wire in both the arteries, and the lower FFR is taken as a guide to decide the intervention or no intervention. The problem comes once we have a sequential lesion. So you can see there is a lesion in the left main and there is a lesion in the LAD. So the first step is, now we know if the wire is kept in the circumflex, the maximum hyperemia that can be achieved will be very limiting because of the LAD lesion, and hence it is likely to elevate the value of FFR. That is, it will come falsely negative if there is a lesion in the LAD which is not assessed. So what do we practically do in such things? First step is we measure the FFR across both the lesions. If this is more than 0.8, we know none of the lesions is important and no need to do anything further. Now, if this wire in the LAD shows the FFR to be less than 0.8, then we are supposed to measure the FFR in the L6 with the above caveat that it will come falsely high. Now, to solve this problem, so what we think for now is if the L6 FFR is more than 0.8 here, that means this lesion is not important and only LAD is important, and we can go ahead with the LAD stenting. Problem, if you send the LAD, the flow will increase and then FFR might become significant. That is what is the current worry. But to solve this conundrum, there is a very beautiful study done by this Fearon et al. Group. What they did is they put a balloon in the left main, one balloon in the proximal LAD, and there are two pressure wires, one in LAD, one in L6. Now, left main balloon is constantly inflated to simulate a left main lesion. Now we are going to see what is the effect of this balloon inflated in the LAD or a lesion in the LAD, how it affects the FFR in the LCX. So initially a FFR is calculated called as true FFR, that is FFR measured in the LCX with no lesion in the LAD. Then we inflate the balloon serially in the LAD and measure the FFR in the LCX. That FFR was called as apparent FFR. So FFR value after inflating a balloon in the LAD to simulate a LAD lesion and to see how much does this lesion affect the FFR in the LCX. And what they found was quite interesting, that this FFR epicardial is the FFR of the LAD vessel to see how tight is this lesion. So across all the lesions severity of LAD, there was not much difference in the true and apparent FFR. The actual difference that they found was like 0.01 when the FFR value of this LED wire was between 0.45 to 0.74, which means it's quite tight lesion. And despite this lesion being tight, the difference in true and apparent FFR remained very low, 0.02. Only when the lesion in the LED approached total occipital occlusion, only at that time the FFR, there was actually some difference between true and apparent, and that difference was also never more than 0.05. So what we conclude is, if there is a lesion in the LED, the effect of that lesion on the wire in the LCX, which measures the FFR of the LM lesion, is quite small and practically negligible. So now to answer our question, when there is a lesion in the LED and a FFR across this both LM and LED lesion is significant, we pass a wire across LCX, measure the FFR, and if this FFR is less than 0.8, we know LM is significant. If it's more than 0.85, FFR cannot be more than, if it say cannot be less than 0.80, as we know that the difference that this treating a lesion LED would cause will never be more than 0.05, and hence FFR of more than 0.85 can be very easily taken as insignificant left main lesion. But in real world, what do we see? We see that we don't get left main alone. We have a diagonal lesion, we have a LM lesion, we have LED lesion, OM lesion, LED lesion, distal LED lesion, and hence there is a problem with the FFR in real world. So the role of imaging. Now in imaging, what we know is a significant stenosis. More than 50% diameter stenosis is significant. So we can just measure the LM diameter and diameter of the lumen and calculate this. However, in real life, the plaque is not concentric, neither left main circular. So a diameter becomes very difficult to assess. So MLA, mean lumen area, is the Ivers parameter that we are going to further measure to know the significance of this lesion. So some technical aspects for ostial LMC: distinguish the guide catheter. For Ivers pullback, do it across from both the branches, LED and LCX. There will be a discrepancy between the mean lumen area in these two wires. That is because when you pull a wire from the more dotted vessel, more angled vessel, there's going to be an oblique plane at the ostium of the LED and distal left main. So a smallest of two areas should be used for LMC assessment. Now, what are the current guidelines? The current guidelines suggest that a cutoff of 6 mm square as a mean lumen area for left main. This number came from the first landmark study by this Justy et al. Group, which studied the which tried to correlate the left main area versus FFR. So they found this 55 patients with an intermediate lesion where both FFR and Ivers was done, and then FFR was tried to correlate with the mean lumen area to find out what lumen area can predict a significant FFR. So this is the result of their study. We can see that a mean lumen diameter of 2.8 mm predicts a FFR lower than 0.8, and a mean lumen area of 5.92, exactly a 6 mm square, will predict an FFR of less than 0.75. Hence the current guidelines and current cutoff of 6 mm square as a significant for FFR. If it's a significant for left main, if the area is lower than that. So this value of 6 mm square was later validated by a Spanish litero group. They derived this value of 5.8 based on the Finet's law, presuming that LED is 3 mm, L6 is 3 mm, and with this law we come to a conclusion that the 5.8 mm square area would be behaving as a 75% area stenosis. And once this area was derived, it was tried in a pilot study of 79 patients and was prospectively evaluated clinically in 354 patients with an intermediate left main lesion. So these patients, when the area is more than 6, they were deferred intervention and were followed up medically. Area of less than 6 were intervened on, either by surgery or angioplasty, and both the groups did equally well. Conclusion: that it is easier or it is safer to defer a patient when the area is more than 6. Now, a similar study was done in the Korean population, where they measured the Ivers and FFR in a large cohort of 112 patients with intermediate LMC lesion, and the numbers that they found were quite different from the Listro group and Justy. That an mean lumen area of less than 4.5 and a diameter of 1.9 predicted an FFR of less than 0.8. So this is the mean lumen area which best predicts the positive FFR, and this is the mean lumen diameter which can best predict the positive FFR. So it's 1.9 and 4.8 mm square, and in their study the 6 mm square had a very low specificity, but this was in a Korean population. the best cutoff found by them was 4.5 millimeter square. However, they found out that with this area there are significant mismatch and reverse mismatch. Now, what is mismatch? People who have area less than 4.5 but a negative FFR, that was around 17%. Reverse mismatch was almost 24%, where people had area more than 4.5 but FFR was positive. And hence, to conclude, the cutoff value which best predicted a positive FFR was 4.5 millimeter square. But there was significant number of patients with matching mismatch and reverse mismatch, telling that probably Ivers cutoff of one value is not good for all. So they concluded telling FFR is better for intervention, and Ivers may be used in very complex lesions to defer intervention. And even when they matched for body surface area and LV mass, it didn't improve the accuracy of the mean lumen area. So what do we have? A guideline recommended 6 millimeter square, which has been, that is because it is the only value which is studied prospectively. However, in Western people and in Spanish people, Korean number is 4.56 millimeter square. But again, it's only specific for the Korean. So what is the number for Indians? We don't know. And hence, FFR still is the gold standard for intervening in complex or multiple lesions. So what can we depend on is still that age-old method of measuring diameter stenosis of 50% or area stenosis of 75% should be the first value rather than any fixed value of area. Now let us come to the role of imaging in the by OCT. There's only one study in OCT which tried to see the role of imaging, where more than 100 patients were studied with intermediate LM lesion, and the OCT criteria used for revascularization was area stenosis of more than 75%, who were left. Sorry, it was less than 75%. Stenosis more than 75% or a mean lumen area less than 4 millimeter square. So this was the cutoff used, and these patients did okay if they were operated or managed medically depending upon the cutoff. Hence, if OCT is ever used for left main, a cutoff that is used for area is 4 millimeter square or a area stenosis of 75%. Now let us see the role of imaging in Parkinson's intervention. Now, why Ivers in intervention? There are a lot of studies which showed that Ivers saves life if used in intervention, and the meta-analysis indicated that Ivers guided intervention versus only angiography guided can reduce mortality up to 40% and cardiac death by 50%, and hence Ivers should be a priority in left main interventions. Now what all we are going to assess in pre-PCI: one, plaque composition to see for calcification and to decide the bed preparation strategy; plaque distribution, which can help in deciding 1 versus 2 stent strategy, and to evaluate the aorto-osteal disease burden, and to decide the stent sizing. Now calcium, we have discussed the imaging in calcified lesion in our previous webinar. This is how we calcify: superficial versus deep and nodular. The 3 parameters that we measure are calcium arc, thickness and length. Remember the rule of phi: arc more than 50%, that is more than 180 degrees, thickness of 0.5 millimeter and length of 5 millimeter will predict a under expansion. Doesn't mean it will require a rota, but it will require some form of advanced bed preparation strategy. And what this device based selection also we discussed in the last webinar. What options we have is non-compliant balloon to go up to 1:1 dilatation. Can use special balloons like cutting scoring balloon or atherectomy or an IVL. So to summarize, a concentric thin calcium might respond to a non-compliant or scoring balloon, while concentric thick calcium will require a rotablation or some form of atherectomy, while deep calciums will require special balloons. If it is not responding to special balloons, we can use the IVL. So, and regarding the stent sizing, for OCT, we should have at least 3-layered structure. There should be no calcium nodule or a lipid pool, and length can be assessed by automatic pullback. Add a millimeter of 3 millimeter to the length. For Ivers based landing zone, the plaque burden should be less than 50%, and stent length can be determined by automatic pullback. Also, evaluate the aorto-osteal junction. If there is a plaque burden more than 50%, it means we need to cover the left main ostium. And regarding the stent diameter sizing by Ivers, there are 3 parameters available: lumen, mid-val, and media to media in an increasingly aggressive order. Now, if we use media to media, this should be discounted by a 0.5 millimeter, as it overestimates the diameter. Now, for the post-stending assessment by imaging, again, this was mainly given by this Kang et al., which is a landmark study about trying to measure the diameters after the stenting, where they assessed 400 patients and they calculated the post-stenting mean lumen area in LAD ostium, L6 ostium, proximal left main, and the point of confluence. They have studied around 400 patients. The conclusion: the ISR was around 5% in single stent versus 25% in 2 stents. The most common site of ISR in single stent was left main ostium. In 2 stent strategy, the most common site was L6 ostium. and the area that was used that predicted the in-stent restenosis was 5 millimeters square in LCX, 6 in LAD, 7.2 in the confluence or distal left main, and 8 in proximal left main. And these were the areas below which, if the stent area was lower than that, that predicted the in-stent restenosis. Now, this has been very diagram which is used everywhere in the left main interventions, but know that the area of 8 millimeters square of left main corresponds to a radius of 1.6 or a diameter of 3.2, and we all know it is very less. So this is mainly applicable for Korean population, not for our population. If a LMC has a diameter of 4.5, that corresponds to an area of pi r square around 15 millimeters square. So in a LM of 4.5, the minimum area should be 13 millimeters square with an acceptable 20% under expansion. So this 8 millimeters square, it's good to remember, it's studied only in one population, that is the Korean population, and not in everybody. Like I said, 8 millimeters square will correspond to a diameter of 3.2, which is significant under expansion for our population. So to conclude, rest all the other post-stenting assessment, it will help to size the balloon, to decide about POT, to identify the complications, and to assess the side branch ostium. My next speakers will be discussing about that. Final run, we mainly, among all this, the most important things are stent under expansion and measuring minimal lumen area. Again, under expansion is when stent looks completely opposed, while under apposition is this. Now, my all technicians keep on telling me about the apposition because that is simplest to assess. But more important is to assess the under expansion, which has been the greatest predictor of stent failure, and not under apposition. Most oftenly, malapposition is not associated with subsequent cardiac events, but under expansion is the most important predictor. How do we correct this? To use the nominal size balloon at a higher pressure. To correct this, we use a higher size balloon at a normal or lower than normal pressure. Again, one more for balloon sizing. The artery diameters don't come according to our balloon sizes. It will be 3.4 here, 3.8 here, and 4.7 here. So what do you do about this? A 4 mm balloon or an NC balloon will act as a semi-compliant at a lower atmosphere. So you use a 4 mm balloon at a lower pressures, so it will become 3.4 here and 3.8 here to achieve a full carinal apposition. Now, other than stent under expansion, geographical miss is the second largest predictor of event. How do we define? A plaque burden of more than 50% at the stent edge, and this should be corrected by an additional stent. Stent deformation, when we see multiple layers of stent in a single cross section, or stents measure abnormally short or long. How to correct that is not clear, but at present what we know is if there is elongation with a focal positive stent, use an additional stent probably. If there is a shortening with a stent overlap, use a high pressure balloon dilatation. So to conclude, in intermediate LMCA lesion, FFR is still the gold standard. Mean lumen area, one size fits all is probably not safe to assume. So remember the number of 6 millimeters square for the Western population, 4.5 was used in Koreans. To Indians, we don't know what is the value. So actual measurement of diameter stenosis and area stenosis might be more practical. A pre-PCI Ivers run has been shown to save lives and should be done. Post-stenting, geographical miss, and under expansion are the most important factors to be assessed and to be corrected. And like we saw in ISR that L6 ostium has been the commonest site of in-stent restenosis. So don't neglect L6 ostium, as we all focus on LM and LED ostium. Thank you.
Yeah, thanks, Neil. I think that was a comprehensive review about the imaging. Any comments from you, Sarup, while Anuj gets ready?
Yeah, we extensively covered all the predominant aspects. In the question and answer session, we'll discuss about the under expansion of the stent and malapposition of the stent, because these are the important concepts, and we'll have a detailed discussion about this.
So we'll want to Anuj talk. He'll be talking about the provisional strategy, and after that we'll have Dr. Shahid Machan talk about the two-stent strategy. So over to you, Anuj.
Good evening, everybody. Coming to left main PCI as a provisional strategy, basically left main bifurcation lesions may be treated either by a provisional stenting or a two-stent strategy. Now, when do we use what? Multiple studies that have been done. The definition study basically has been the landmark study for this, where it's been defined as a simple bifurcation versus a complex bifurcation lesion. Simple bifurcation is where the side branch, which generally is LAD, is less than 70% and the lesion length is less than 10 millimeters, which is seen in almost 75% of the patients. The complex left main bifurcation is where the side branch stenosis is more than 70% and the lesion length is more than 10 millimeters. In addition to that, there are two of the either 6 minor criteria that are also taken into consideration are either moderate to severe calcification, multiple lesions, LAD LCX bifurcation angle of more than 70 degrees, main vessel reference, main vessel being most of the times the LAD, vessel diameter of less than 2.5 millimeters, thrombus containing lesion, or a main vessel lesion length of more than 25 millimeters. Now, left main as a 1 stent versus 2 stent strategy. A provisional approach is generally the treatment that is preferable, which involves the wiring of both the LAD and the LCX and stenting towards the LAD with a stent sized according to the LAD diameter and post dilated to the left main diameter. If the LAD is spared from disease and LCX is the culprit, then we stent from LAD to LCX. What should precede rewiring of the side branch, and rewiring should be through the distal strut, which I will show you with the case examples. And in case a second stent is required, kissing balloon inflation with 2 balloons is mandatory, followed by a final pot. This is just a gist of how it's done. It looks very simple, though when we are on the table, it's a little different. Now, after first stent, how do we decide whether we need to do anything for the side branch? In case angiographically it is fine, there's no pinching of the LCX or the side branch, there's nothing, we just pot the left main and come over. If the side branch is narrowed by virtue of the CAG or the Ivers, or we do an FFR and see if there is a decreased flow, and we do a final kissing. If there's a carinal shift, we do a kissing balloon inflation to restore normal flow, do a Ivers and check. If it's only a plaque shift, then we plan a 2 stent strategy and go ahead with the 2 stent strategy. Now, provisional stenting conversion to a 2 stent strategy, what would we do? If the angle between the left main and the LAD and the LCX is more than 90 degrees, T stenting is good because the protrusion of the stent is minimal. In case it is lesser, then either the tap or the culotte stenting is done in a narrower bifurcation angle. Tap generally is easier because of the second side branch rewiring is not necessary, but the amount of stent that is protruding into the left main or the neocarina is much higher. The BBK2 study showed that culotte is much better stenting than much better procedure than tap, because the chance of angiographic re-narrowing, restenosis was much lesser at 1 year. So, what is a vulnerable carina? This is something which we see to the naked eye. This is called as an eyebrow sign, where the angle is very narrow, and there is, as you can see here, there is a very narrow angle here, and the carinal displacement here is much higher. And this kind of circumstance, it is better to go ahead with the 2 stent strategy in most of the cases, because we would end up with that in case we are doing a provisional either ways. Just to summarize the provisional versus 2 stent approach, the left main bifurcation, if the side branch is less than 70%, the lesion length is less than 10 millimeters, and the side branch is easy to access, then we go ahead with the single stent provisional stent strategy. Once the stenting is done, we assess the side branch. If it's fine, or the FFR is less than, if FFR is less than 0.8, or there is a compromise in the flow, we convert it to a 2 stent strategy. And in case the side branch is not easy to access, we take in a wire, and then we may convert to a 2 stent strategy initially itself. When it's a complex lesion, anyways, we go ahead with the side with the 2 stent strategy. The DK, most of the times with DK crush, and that will be taken care of by Dr. Shahid, which he'll probably illustrate. And the evidence-wise, the DK crush 2 study also showed that patient with a simple bifurcation lesion, provisional stent strategy is much better compared to a DK crush, whereas in a complex lesion, DK crush was fared much better. Now I'll probably illustrate my thing with a little bit of case examples. This is a 60-year-old lady who's a diabetic, came in with a recent NSTEMI, had mild LV dysfunction. This was the angiogram. It's an ostial LAD lesion extending into the proximal LAD, titus being in the proximal LAD. If you can see here, the angle between the side branch, the LCX and the LAD is it's a very narrow angle. Here the issue was it was a left main 010 with a very mild LCX osteal involvement. So what we did was we took a 7 French catheter up front with GP inhibitors. We thought of a provisional stenting of left main crossover into the LAD. The unfavorable factors were only the narrow angle, which had a more likely chance of a plaque shift, but it was easier to recross. So what we did was we put in 2 wires, pre-dilated the LAD lesion, took a stent from the left main to the LAD, deployed the stent. Then we did a pot with a 4.58 atmosphere 8 balloon. And after that, you could see that there is a osteal narrowing of the LCX. There's a significant plaque shift. We thought we'll just do an FFR and see. So what we did is we let the wire be. We took another FFR wire, went into the LAD, and then crossed the lesion from the distal strut. The FFR baseline was 0.96 and post the adenosine it was 0.88. So we decided to actually leave it alone. This was the final shot. So a patient came recently also for a 3-year follow-up, was asymptomatic, and case of the side branch. So basically was asymptomatic. We left it alone because the FFR was fine. Then so basically here side branch narrowing every time may not be significant, even though angiographically it looks significant. It could be just due to a shift in the carina, and FFR generally is good evidence to say whether we should intervene or not. The second case here was a 74-year-old lady, hypertensive diabetic, had recurrent rest angina, had NSTEMI with a Wellens sign on ECG, had moderate LV dysfunction. Background was she had CA breast, was post-surgery, post-radiation and chemo. This was her angiogram. She had a left main disease with an osteal LAD and a long lesion extending into the LAD. Had a mild circ disease as well, osteal. The heavily calcified lesion. It was extremely acutely angled LAD from the circ. If you look here, you can see the LMCA distal had a chunk of calcium at the bifurcation. The issues that we were dealing with here was the acute coronary syndrome, left main 010, a long LAD lesion, osteal circ and diagonal moderate disease, densely calcified left main with an acute angle of the left main to LAD, and CABG was not feasible because of her radiotherapy and post-surgical status. So what we decided was we had a meeting, we all sat together, had a 7 French, we thought of a 7 French guide, we thought we'll rotate the left main to LAD, access the LCX ostium, do a provisional left main to LAD stenting and then decide on what has to be done. Pre-Ivers we thought was not necessary because it was an extremely calcified tortuous disease and there was no ambiguity about the lesion or the decision of rota. Generally, in dilemma for any of these reasons, we would use a Ivers even in the pre-stenting. So what we took in a wire, regular wire with a fine cross, fastened the wire, took a rotablation. We were very gentle in using a 1.5 burr at the ostium because it was acutely angulated. Rotate the proximal part of the LAD and the left main. Removed the wire and exchanged it for a BHW. Pre-dilated the complete lesion length of the LAD and the left main. And after all this also, the stent wouldn't pass. So we took in a guideliner as well. We tried telescoping it also. Still stent wouldn't pass. So here it was actually not only the calcium, but also I think the angulation. So what we did is we used 2 BHW as a buddy wire technique, and after that it was we could pass the stent. After that, stent went in beyond. Removed the second wire. deployed the stent, did the pot with a 4.5 and a 5 millimeter balloon. But thought we got away with that. But then if you look at the ostium here, there is a little of clot on the ostium. So then had to pass in another wire. We went in again. We amplathed the tip of the wire, made a double curve, passed the wire from the distal edge, distal struts, took in a balloon, did a final kissing there, did an Ivers run into the LCX ostium, saw that there was no dissection or thrombus in the LCX ostium. The left main final lumen area also was around 13 millimeter square, and this was the final result we achieved. Patient did well after that. Got away with one stent, though we had to kiss the both the ostia. Patient's doing pretty well after that. So basically, Ivers for the LCX or the side branch basically is useful deciding about the side branch strategy after left main provisional stenting. In case there is no dissection or there is no major plaque shift, then we can actually get away with one stent. And understanding the mechanism when we are not able to deliver a stent or a guideliner is very important, because here the simple body wire technique helped, and it's not always just the heavy equipment that we use that is necessary. This is the third case. This is a 50-year-old male who was status post PCI to LCX ostium 3 years ago. Now had an STEMI with good LV function. This was his angiogram. Right coronary was absolutely fine. LCX, if you look at it, LCX absolutely, the stent had no restenosis, but the ostium of LAD had narrowed down significantly. He had significant angina, even postprandial angina. This was his angiogram. So now the issues here was the LAD ostium was tight, the LCX struts extended into the left main, and it was a narrow angle bifurcation. We took in a 7 French guide. We thought of a distal strut crossing. We thought of this as a 2-stent strategy with 1 stent already there in the left main, in the left main to LCX, and we thought we'll pot the old stent and go ahead with a reverse culotte. Pass the wire from the distal strut. Wire surprisingly went in pretty easily. We really dilated the LCX ostium with the 1.5 and then 2.5 balloon. It was pretty tight narrowing there. Then did a kissing balloon basically to open up the artery, and didn't want to crush the stent there. We didn't want to narrow the ostial LCX stent. We did a kissing balloon there. Then removed one of the wires, took a guide liner up to the dilated part of the strut, because we didn't want the stent to get stuck in the thing. It would actually damage both the stents. We took in a guide liner, delivered the stent across the guide liner, across the left main, inflated the stent. Did a pot, and finally kissed, recrossed, kissed. Final pot. This was the final result. Went in pretty high actually on the atmospheres. There was a little bit of residual lesion, but patient's fine. So this basically we wanted to just show, because across the stent and stent, basically the use of the guide liner there was very important, because we had a case where we actually had a stent that got stuck between the struts. When we were trying to reposition the stent between the dilated struts and the new stent, it gets stuck and both the things get damaged. Then you end up crushing both the stents. There's so much of metal there and ends up in re-narrowing. Now this is the fourth case. This is an interesting acute interval MI with a window period of 8 hours. This is a 43-year-old smoker. Came in with borderline pressures. It was taken for a primary. This was an angiogram, had a super dominant RCA. There's heavy clot burden from the left main into the LAD. long lesion in the LAD, had a clot extending into the left circumflex as well, though the circumflex was small. You are basically huge clot burden. So we didn't, this was in the middle of the night. Now what to do with this guy? Basically, everybody came on, pitched in here. Basically, plan was whether to do a left main PCI, a young fellow smoker, whether to just give thrombolysis intracoronary or intravenous, or do a GP glycoprotein inhibitors plus heparin and check later. So what we all thought was give GPI, wait on the table for 15-20 minutes and check. And this is what it was after 15-20 minutes. Luckily, patient was on table. Everything got occluded. So immediately passed in a wire, opened up the LCX, did a thrombosuction. LCX got occluded. Passed in a wire, opened up the LCX with the balloon, LAD gets occluded. Now, we thought we'll just keep it simple. LCX anyway was very small. LAD was the main culprit, so stented from left main to LAD. Recrossed the LCX with the wire there. We recrossed the LCX. Balloon dilated the LCX. Got in a little bit of flow. Not very encouraging in the LCX, but then LCX was sacrificable at that point in time. Had an IVP in place. Thought we'll leave it there because we got a tide over. So here, basically, the take-home patient is doing well. He had a little torrential course in the ICCU for 3-4 days. Settled down after that. Renal parameters were a little elevated. His liver parameters got a little elevated, but settled down comfortably. Came back for a follow-up also recently. The take-home message in this case was basically GP2Bs and heparin is good in complex thrombotic left main lesions. But it's always better that when we are going to leave the patient alone with only that, better to have a check angiogram after 15-20 minutes to see if things are working the right way, or otherwise it doesn't give us enough time. Stenting may be the simplest option sometimes, and it's always better to keep it safe and simple in these kind of circumstances. Conclusion: provisional left main stenting is the most favorable approach whenever feasible. Pre-procedural planning is a must. Honestly, to be very frank, in all the 4 cases that we have shown, all of them were completely discussed with the group of cardiologists that we were. None of them were done as an ad hoc. We had plan A and plan B in place in all the cases. Ivers and FFR come in handy for left main optimization and for decision making, especially for side branch assessment, and undertaking the basic cause of problem and addressing helps us most. Thank you.
Yeah, thank you, Anuj. I think the cases you have shown gives us a lot of confidence in doing provisional stenting. But I am sure Dr. Shahid Merchant has cases to show from his side. So I think we'll move on to Mumbai and Dr. Merchant for his talk on step-by-step approach for deconstruction in left main. People who have mastered that generally are extremely comfortable as far as main is concerned. Sir, good afternoon, sir.
Good afternoon, Rajiv. How are you?
Good, sir. Hope you are doing fine there.
Sorry, yeah, everything is okay by God's grace.
See you. I'm not sure if you had just introduced you. So
Yeah, thank
they
you.
told us that the video is not on. And so we are all waiting to hear from you, sir.
You okay, Ashish?
Yes.
Will it that small? Can we make it big? Are you seeing my slides,
Yes, sir.
Rajiv?
Very well, very well.
Okay, thank you, Rajiv, for inviting me for this particular meeting. I'm also going to keep it simple. I'm not going to discuss too much of data and studies and trials and tables and diagrams, but try to keep it simple so that it's understandable by we colleagues and also by our fellows who are watching us in good numbers today. So as we know that left main has many sizes and shapes, and as you have shown many cases of ostial LAD and then the distal left main and the ostium of the left main and the diffuse disease of the body of the left main, the circumflex which has tortuosity and calcification, and so on and so forth. So these are all the variations that you find in the left main, and left main comes in many sizes and many variabilities. So distal left main represents 80% of the left main lesions. And we know that in the distal left main, the burden of atherosclerosis is high. And also there is relative involvement in both the osteo of the LAD or the circumflex. And we know that advanced atherosclerosis in distal left main is more in the proximal LAD than in the left main or in the left circumflex. So what about the bifurcation angle in the distal left main? We know that the average left main and circumflex angle is greater than 90, and the left main LAD angle is more straighter, and it is less than 60. We all know that metal fatigue is a problem, especially with an acute angle, which predisposes to strut fracture when you deal with the distal left main. Also, we know that there is areas of low shear stress, and that promotes ISR. So if you look at the crush technique and the influence of the bifurcation angle, and if you look at both the Y shape and the T shape, and if you look at the mace free survival, it would be better with a Y shape than a T shape. But in the DK crush 5 of Shen, a lot of cases of T-shape in a distal bifurcation have also been involved, and we see that the results are equally good with a DK crush. So what are the problems of stenting from left main to circumflex? As the previous speakers have shown, that if you look at the left main bifurcation, and if you look at the guide wire position, on the proximal position of the wire is outside, the middle is inside, and the distal is again outside. And we all see that there is a dumbbell shape to the balloon. Now, when you look at the stent here, there is a hinge motion between the left main and the circumflex stenting, which causes the fracturing in the structure of the struts of the stent, which are stretched of the left circumflex at the ostium when you do a crossover from left main to left circumflex. So if you look at the stretch struts, and if you look at the guide wire position, there is really no change in the position of the guide wire. But if you look at the balloon dilatation, it is definitely non-uniform. And if you look at the proximal balloon, it is over-dilated. If you look at the mid balloon, there is like a dog boning to the balloon in the stent. And then you look at the distal balloon, again, it's over-dilated. And you look at this particular gap, which is the ostium of the side branch, through the stretch strut of the stent. So in selecting the strategies, as the previous speakers have shown in the different cases, the left circumflex is the key element for the strategy for the left main bifurcation PCI. And your whole strategy will depend on the size of the circumflex, the area of the jeopardized myocardium supplied by the circumflex, the ostial location of the plaque, the diffusion of the atheroma in the circumflex, and surely the bifurcation angle. So which stent technique will you use? Now, all that will depend on the patient's clinical status. As the previous speaker has shown, that in a cardiogenic shock with a low blood pressure, the patient had almost a thrombotic occlusion of the left main, and then quickly he had to just stent and do a provisional stenting between the left main and the LAD. And on that patient's clinical status, you can't venture into a DK crush. Also, it depends on the anatomical characteristics, mainly calcium, tortuosity, and thrombus, and obviously the operator expertise. So the final result is more important actually than the technique used, which has been very nicely shown by the previous speaker. Now, if you look at the this algorithm on the left main bifurcation, and you do an Ivers study of the LAD and the left circumflex, as we know, and you've shown in the previous cases, if it is a diminutive or a small or a non-dominant circumflex, or if there is a minimal or no disease at the ostium of the circumflex, then you just use a single stent, which is a provisional technique, which has been cases. Just crossover left main to LAD. You can use an Ivers, which you've already shown. Now, if there is a side branch, there's no chest pain, no hypertension or ST changes, leave it alone and you finish your PCI. But as you've shown that if there is a jailed side branch, you put an FFR wire, IFR wire, and you see if it is less than 0.8, then you can use a final kissing balloon or a T-stenting. And if the FFR wire is greater than 0.8, then you just finish your PCI and do an optimization with Ivers. Now, the main issue comes when there is a true bifurcation, when there is a big left circumflex, when there is a diffuse disease in the left circumflex, then you have to use a two-stent strategy. And in the two-stent bifurcation angle becomes very important, more than 75 degrees or less than 75. So if it is more than 75, as we all know, we use a tap or a DK crush. And if it's the same size main branch and side branch, you can use a culotte or mini crush, a tap or a DK crush. And if there are different sizes, then you use a tap or mini crush or a DK crush. And this is a chart which is put in my cath lab as a protocol in algorithm that we use with Ivers optimization with two-stent technique. Now, majority of the left main bifurcation goes with the provisional stenting. So this is a diffuse disease in the bifurcation, and here there is a single crossover left main to the LAD. Now, if you look at the survival free from cardiac events between one stent and two stent, obviously in the COBIS trial registry, which was 850 patients, a Korean study which showed that provisional stenting is better than two stenting. But now when you look at left main and non-left main, yes, in non-left main provisional is fine. But if you look at this particular study by Song et al., it was almost 80% of patients had one stent and only 20% had two stents. But if you look at the left main bifurcation, then almost 40% of patients had two stents and 60% of patients had the provisional stenting. Because if you look at the TLR in left main in this particular study, with two stents, the TLR is close to 20%, and with a single stent, it's 5.6%. Now, if you look at the DK Crush 3 by my very good friend Shen, you see the left main bifurcation unprotected. And if you compare it with Culotte, obviously DK Crush scores with the cumulative TLR free survival as compared to the Culotte group. And if you look also at MACE at 5 years in unprotected left main bifurcation, and if you look at DK Crush as compared to others, you see that the cumulative survival free MACE at 5 years is much better with DK Crush than with Culotte, than with TAP, with kissing stenting, and with the classic Crush. So all of us know about the definition 2 trial, and the previous speaker did speak on the Medina classification 011 or 111 bifurcation with a side branch reference vessel diameter equal to or greater than 2.5 mm. And if you look at complex bifurcation based on the major criteria, which we all know now, side branch greater than equal to 10 mm, and the vessel diameter having a stenosis of greater than 70%, and the minor criteria depends on the length, thrombus, calcification, bifurcation angle, and the complex bifurcation lesions are when you have one major and any two minor criteria. And in the set definition 2, we randomize them into a 2 stent versus the provisional stenting. So these are the steps of the DK Crush. We all know this. There's nothing new in this. Distal left main bifurcation, and you wire both, pre-dilate both. You've deployed a stent here with 1 or 2 crush into the left, 1 or 2 struts into the left main. You crush with a balloon. You do a proximal cell kissing, and then you proximal case crossing, and then you do a kissing balloon. Sorry for this interruption. It just computer hanged, you know. Sorry. Okay, so this is the here is the crush and the final kissing. So this is the pot, and then that's the final result, the repot and the final result. Sorry, guys. Okay, So if you look at the pot, in the pot we do a stent diameter according to the distal main branch. We all know this. And we know that the pot needs to be done before you do an additional guide wire insertion through the cells of the stent. And we know that one has to use NC balloon, which is short, and it's sized to the left main and positioned just up to the ostium of the LAD. We know that there is a better stent position that way, and that it also facilitates a side branch access, especially the distal recrossing. So a final kissing balloon in the single stent technique is not always good. So leave it alone actually can be better unless the patient has chest pain or ST changes, or there is a reduced TIMI3 flow in the side branch, or if the FFR is less than 0.8. So if you look at this particular AMC data, leave it alone versus a routine final kissing. And if you look at the cumulative incidence, it's better in leave it alone rather than do a routine final kissing. Now, if you look at a final kissing balloon and the carina, if the left main branches are large, then two stent technique is indicated to preserve the size of the vessel. So if we implant only one stent, now as the carina is very soft, you know, carina is not hard. Carina does not have atherosclerotic lesion. So the carina is going to move on the other side and there'll be pinching of this large side branch. So it's best to put a second stent here so that now if you put a second stent, then again the carina will be shifted towards the opposite side. So in which case, it's best to do a final kissing balloon, which will give a uniform deployment of the stent, and the ostium of both the left main and the side branch is going to remain nice, open and round. So if you look at the effect of the final kissing balloon in such a situation, there is minimal overlap and you see a nice big rounded side branch, unlike a long overlap of the struts of the stent. So what is optimal kissing? Optimal kissing is when the balloon size is according to the distal reference, and you need a short and a NC balloon. You need a short overlap of the NC balloons in the left main. So don't try to hang both the balloons into the left main. So the side branch first and then simultaneous kissing is what is recommended. Now you can kiss for 20 seconds to 30 seconds. So at least that much in case the patient can tolerate it, but a hemodynamically unstable patient may not be able to tolerate a 30-second optimal kissing. And a final pot, as you all know, is mandatory. Now, as shown by the previous speaker, you look at the left main bifurcation, anatomy versus FFR. So if you have an angiographic jailing, you will find in 42% of cases. But if you do an FFR, you may land up with a functional jailing of only 7%. So actually there's a 35% risk for unnecessary PCI, final kissing balloon and stenting to the side branch, which may not be required if you do functional testing. So Ivers, you know that the Ivers guidance in left main, distal left main especially saves life. And this has been shown again and again by Park et al. In his various articles in 2009 and subsequently. So the angiography guided versus Ivers. And if you look at the cumulative mortality is 16% with angio guided, and with the Ivers guided, it's down to 4.4%. So because the Ivers guidance becomes mandatory, and this is mainly for the left circumflex disease status, for the stent size selection, and for the optimization of the stent. And as I told you, that FFR guided decision for further treatment of side branch is extremely important. So if you look at the left main bifurcation, distal left main bifurcation with an insignificant disease in the ostium of the circumflex, which is shown on the Ivers, a single crossover left main to LAD, and you see the Ivers has been done, and the post Ivers, it is showing the LAD, the struts of the stent are well embedded. And if you look at the circumflex, this is a FFR negative with only a mild plaque at the ostium of the circumflex. This is an eccentric plaque with a slight fibrofatty tissue. So what is the clinical impact of the Ivers and drug-eluting stent for unprotected left main? As I've already told you, that left main 2-vessel stenting, if you look at cardiac death, MI and TLR, Ivers guided definitely helps as compared to non-Ivers, and doing just on the basis of angiography. This we've already, everybody knows this. that there are criteria for stent under expansion, and that if you do stent under expansion and achieve smaller MLAs than the 5, 6, 7, 8, it predicts restenosis. And the restenosis with under expansion will be close to 24%. We know that this 5, 6, 7, 8 is for the Caucasian, for the Asian population, and for the Caucasian population, which are larger 6 feet people. These dimensions are 6, 7, 9, and even 10 millimeters square is what you need as an area to be achieved in the left main and in the polygon of confluence. So lesion preparation in the left main is very important. We know that the left main disease is more calcified. We know it's more fibrous. We know there is greater angulation, and we know a very planned and a thoughtful team approach is extremely important. We also know that when you do a distal left main, you have to do a good lesion preparation. Cutting balloon, rota, scoring balloon, OPN, IVL, orbital atherectomy are all clinically important for the success of a distal left main. Now, my very good friend Ziad Ali keeps telling me that Shahid, what we have to do is we have to do OCT into the left main. I'm still not too much convinced. For sure, at the ostium of the left main, no. OCT has often artifacts in the proximal part of the left main. In the body of the left main, distal left main, OCT may allow optimal imaging for distal left main and ostial LED and left circumflex. You see, these are the artifact frames, but in the proximal left main, mid left main, distal left main, we are quite okay because there is less artifact as compared to if you deal with the body of the left main or the very proximal left main. So what is the European Society of Cardiology consensus? Consensus is optimized treatment class 2 indication is to use an Ivers to achieve the best results. Now, how can you improve the OCT quality in the left main? So try to have your guiding catheter coaxial, and don't let the guiding catheter point upwards, because when you inject the dye with a guiding catheter pointing to the roof of the left main, you will not get very good imaging into the ostial images. So look for a better guideline catheter alignment and check with the test injection before you do acquisition in the left main. So you see how to improve the quality. As I told you that in this particular case, I have kept the guiding catheter at the roof of the left main and injected, and you see this all swirling of the blood, and I've not been able to delineate the body or the distal left main on the OCT imaging. But here, if you see, this is a very clear, nice rounded left main that you can see. Now, if you compare the Ivers with the left main OCT, you see many times, though this is a 40 megahertz, but soon in my hospital, we are going to get a 60 megahertz HD. But just now we are also working on a 40 megahertz. You see you can see that there is a very important medial dissection in the body of the left main, which is not so very well, you can see the dissection, but here you can see a very, very good imaging in the left main with the OCT. Now, if you look at the struts of the stent, so yes, they are malopposed, surely, and we used to be very happy with this until the OCT came. But today you see if you want to look at the malopposed struts of the stent, you see it visibly so nicely, and you actually see the distance between the strut of the stent and the wall of the arterial wall is seen so clearly that you can actually, by artificial intelligence on automation, find the exact separation between the strut of the stent and the wall of the left main. So yes, there has been studies on the OCT Ivers comparison in the left main, but this is very minimal data, and I don't want to get into this particular data. Ziad Ali has also done a particular study on the Ivers versus OCT, and there are comparative studies. But for the ostial of the left main, Ivers, full stop. There is no discussion. In a distal left main, yes, you may do an OCT to look at the distal left main, the proximal LED and the proximal circumflex by OCT. Now, what about stent sizing pre-PCI OCT? Can the EL be identified at both the proximal and the distal reference segment? Yes, because the reference stent diameter decided by the OCT measurement of EL to EL diameter at the reference site can be obtained very clearly with the OCT. Now, we used to say when you're using an Ivers, you minus it by 0.25, and with the OCT, it gives, you can maybe add a 0.25 or let it remain as it is. But really, the Ivers with the HD 60 megahertz also gives you a very accurate measurement on the reference diameter of both the proximal and the distal segment. And yes, on the OCT, it's based on the smallest mean lumen diameter and at the reference site. And this is at the important also is that you get the stent length, and on the OCT this is automatically you get it. You don't have to do much work. You know what we do in the Ivers and what we are used to doing with the Ivers, sitting with the technician. This is more on artificial intelligence and gives automatic references. So what is important in a PCI OCT when you are doing for a left main? Yes, you will need to dilate the LED, the ostium of the LED, if you are trying to investigate the LED and the circumflex with a 1.5 millimeter or a 2 millimeter balloon, so that you can visualize the distal reference if the lumen, a degree of the lumen obstruction interferes with the clearance of the blood. Because if the dye is hanging in the distal LED or the circumflex, it may not give you good imaging. There will be swelling of the blood in the lumen. At the same time, you may induce some ventricular fibrillation. So that is important. But yes, for stent sizing, stent implantation, this is Yardley's MLD max, which we all know now, on post dilatation, on morphology, on length, on diameter, on achieving the target MSA, to look for medial dissection, to look for position and expansion, and the final OCT imaging is all well known to us. So if you look at this 57-year-old gentleman in my hospital, where we had a distal left main, and you see stress test was a positive, and we did an angiogram. And first we have done a IFR, because to me these look like moderate lesions. The right coronary artery was normal. But if you look at this IFR, it was 0.73 in the circumflex and 0.74 in the LAD. And hence we have used 3 wires. There's a run-through wire in the LAD. There is a BMW wire in the ramus, and there is a cyan blue in the circumflex. And the PCI has been planned. The planning is normal to normal. Planning is to look at the distal reference with OCT. You can use an Ivers also, and we've used both here because this was a teaching which we were doing for our DNB students, and left main size mismatch. So if you look at this particular Ivers, actually, we got the Ivers machine 60 megahertz from the company who just loaned it for teaching purpose and academic purpose. And if you, we have looked at the distal reference of both in the OCT and in this Ivers HD is the same. So this will actually give you the same distal reference diameter as compared to OCT. And if you look at but the most important part in the according to me is both the automation and the length and the angiographic co-registration. And more than anything else, I also look at the lumen of the side branch in the left main. Now you see this is the ramus lumen, and this is the circumflex lumen. And so beautifully the lumen is seen. I won't be able to see this in an Ivers. And I have shown these images also to Ziad Ali when we met. And I told him that you see the way these images look, especially at the ostium of the circ and the ramus, that if there is any plaque, or if there is any narrowing, or if there is any problem, and when you are thinking of a 2-stent, a DK crushed versus a single stent, your life is much easy. And the stent length, you all know, is all by automation.
Sir, Dr. Merchant,
So again,
sorry,
you know,
sir,
people,
sorry to
yeah, just
interrupt
5 minutes more.
Yes, sir.
5 minutes more.
Because
Dr.
these
Somaraj.
people might suddenly disconnect.
Okay.
We have time only till around 4:11, 4:12,
Okay,
I think.
thank
sir.
you.
Yes, sir.
Thank you,
Please go ahead, sir.
Rajiv.
Yes.
Thank you so much. So if you look at the left circumflex, and if you look at the, this is the Ivers, and this is the OCT, and you see we talk about a poor penetration, but if there is like a calcium here, you will not be able to get a deeper penetration. And here you, yes, so if you are looking at a lipid pole, even in a pool in an Ivers, you may not be able to detect the same. So this is the proximal reference, and this is what we did was the balloon dilatation and then the post dilatation, and this was the imaging. Yes, I agree that there is a swelling of the blood here when I've done the OCT of this left main, but yes, you have to be careful and do a proper. So let me, this is just the reference on the, and these are the 3D, we're looking at the side branches, and that's the final result. So let me conclude by showing you the DK crush of 5. My hospital was involved in the DK crush 3. And you see the baseline, and so this was a provisional stenting, and at the end of 6 months, this was a case involved in the DK crush by Shen, and there is a tight stenosis of the ostium, and your post DK crush at the 13-month follow-up, you see a beautiful result. So multi-center randomized, I've already told you about this and the result, and this is the final approach to DK crush stenting. 2 wires, pre-dilate the circumflex, stent the left circumflex, always have 1 or 2 struts into the left main. You crush with a balloon. So I do a 2-step balloon crush, 3 mm balloon in the LAD and 4 mm in the left main. And I do not remove the wire in the circumflex. I take at least 2 views to make sure that my rewiring is in the proximal cell. I can use an OCT to look at the proximal cell, and then I do a 2 mm overlapping of the 2 balloons in the main vessel, and I do a side-by-side balloon inflation. Then I remove the circumflex wire before stenting the left main to the LAD, and this is a 4.5 mm NC balloon with which a pot is done. Now, if your main vessel stent is not covering with the ostium, then be cautious that do not cause a dissection in the ostium or the proximal segment of the left main. And when you are rewiring from the proximal cell, Shen personally told me that Shahid, you can do it in the mid cell too. So it's not necessary that you have to go in the proximal, especially if you are doing a rewiring. You can use an OCT to look at the proximal, but yes, even if you go into the mid cell, it's no big deal. And a second kissing, you know, after the sequential inflation and the final pot and the final result. So the key points are to have this balloon not protruding too much into the left main. So if you have too much 2 balloons protruding into the left main, you will cause problems and dissection in the ostium or the proximal segment of the left main. And if you look at the pot also, the pot has to be up to the carina, as you all know, to prevent the distortion of the stent. So let me give you a take-home message on these particular steps: short protrusion, balloon crush, rewire proximal cell, sequential inflation, first kissing, stent the main vessel, rewire proximally, sequential inflation, second kissing, and final plot. So for all left main bifurcation, this is a diagram which is stuck into the wall of a cath lab, and everybody follows this particular protocol or algorithm. So my final thoughts are that there's increased frequency of PCI in the left main bifurcation. And yes, provisional stenting continue to be the default strategy. Yes, we are now using 2-stent technique in up to 40 to 50% of cases. Yes, DK crush seems to be, to me, the better 2-stent strategy, not because Shen is a friend. Integrated use of FFR, Ivers, OCT. Yes, I also believe that OCT in a distal left main is a good option, and that yes, but the most studies have been done with the Ivers for the optimization of the Stent and the PCI. Thank you so much for a very, very kind and patient hearing.
Thank you so much, sir. I think.
Thank you, Rajiv. Thank you, Somaraju, sir. Thank you, all my colleagues, all my juniors, and all my DNB residents.
Thank you, sir. Actually, Dr. Somaraju also was online and listening to your talk. And I think, as I mentioned, we are just running out of time. So we'll close the session. And thank you so much for the wonderful lucid representation of left main bifurcation. Thank you, and thank you everyone for attending. I think some of the questions we have answered online. You can actually mail us, and then we'll answer the questions if anybody else has some other questions. Thank you, sir.
Thank you, Somaraju, sir. I remember having met you 30 years ago, and you took me in your car to the hospital, to the care hospital. I had come for a conference in Jubilee Hills, and then you drove me in your car to see the hospital. Thank you so much, Dr. Somaraju, sir. Thank you, Raju, and thank you all other my colleagues.
Thank you.